Good morning, everyone. My name is Isobel Harrison, and I'm a researcher on the SINAPPS trial and the PPIT study. Welcome, and thank you for joining us on this first presentation of our webinar series for 2021, which is on inflammation and psychosis. And before I hand over to today's speaker, I'd like to give a few details regarding the webinar. The presentation will last 20 minutes. And that will be followed by 10 minutes to answer your questions. And as all attendees will be muted to avoid background noise, please use the Zoom chat facility to submit your questions. Should we not manage to answer all your questions in the webinar, we will collate them in a document which will distribute in a few days' time. And please note that this and the following webinars over the next few weeks will be uploaded onto our YouTube channel and on our website, so they can be accessed at any time. So without further ado, I'm pleased to introduce today's speaker, who is Dr. Jonathan Rogers, who is a Wellcome Trust Clinical Training Fellow at UCL and a Specialty Registrar at South London and Maudsley NHS Foundation Trust. Jonathan will give us a presentation entitled Catatonia, Infection and Immunity. Thank you, Jonathan. Over to you.
Thank you so much for the invitation. It's lovely to be with you this morning. And your back catalogue of YouTube lectures is fantastic. I've been watching them over the last couple of weeks. Catatonia is a condition that is a psychiatric movement disorder and features lots of German terms like Gegenhalten, Mitgehen, Mitmachen, but fundamentally it's often a stuporous and occasionally an excited state with various positive symptoms such as mannerisms, stereotypies, and echo phenomena. And in recent years, there's been a growing interest in this idea of its relationship to infection and immunity. And it's actually a particularly topical idea because there's been a lot of speculation about encephalitis lethargica recently, which started, first case reported around 1915, and it peaked the onset peaked in the 1920s. This is a condition that was a sleep disorder, frequently featuring hypersomnia, though occasionally insomnia, and also a complex movement and neuropsychiatric disorder. And many of the patients in the subacute phase had catatonia. It was brought into the public gaze by Oliver Sacks's book Awakenings and the film adaptation of it. And there's been a lot of a lot of interest in encephalitis lethargica over the last year because it was an epidemic neuropsychiatric disorder that may well have been related to an epidemic infection and possibly an immune reaction to it. I'm going to talk about two hypotheses for catatonia and the immune system. And we'll try to evaluate those as we go through this presentation. We're going to talk about infective causes of catatonia, autoimmune causes of catatonia, and some of the inflammatory markers that have been found in patients with catatonia before rounding up. And I'll try to keep this clinically relevant and helpful for the patients you're seeing. I'll be basing some of this on our Lancet Psychiatry paper a couple of years ago, in which we reviewed the evidence for the role of the immune system in catatonia. So, two hypotheses for catatonia and the immune system. The first is what I'll term the systemic inflammatory neurovegetative hypothesis. And if that's a bit of a mouthful, we'll call it the vague hypothesis. Okay. So this is the idea that in catatonia, there is systemic inflammation somehow. And systemic inflammation has been associated experimentally with psychomotor retardation and withdrawal in animals. And also you see it in humans after systemic viral and bacterial infection. You get a state that approaches some of the features of catatonia in terms of the withdrawal, reduced interaction with the environment. We know that in depression, there's evidence for increases in some of the pro-inflammatory cytokines, or at least in a subset of patients with depression. And in its extreme, particularly in the melancholic depression, you get a psychomotor retardation. And in animals, there's some evidence that glial dysfunction, so in knockout mice by Hagemeyer, where we knock out a gene involved in glial function. There is a catatonia-like phenotype in these mice. So it's possible that systemic inflammation may be driving catatonia. This is the vague hypothesis. Our second hypothesis, we'll term the neuronal autoantibody-mediated hypothesis, and this is a much more specific hypothesis. So this is the idea that autoantibodies directed at specific, probably extracellular neuronal antigens produce specific neuropsychiatric syndromes, such as catatonia. Okay, so these are the two theories, and we're going to examine them as we go through and see to what extent they hold. Let's start by looking at the infective causes of catatonia. Now, to warn you, on the next slide, there is a huge range of infections that have been associated with catatonia, and I don't show them so that you can memorize them, but just so that you get an idea of the spectrum here. So we have viral infections, we have bacterial infections. Some of them will be fairly familiar to use, HIV-related, syphilis. Some of them are what you might expect, so viruses and bacteria causing meningitis or encephalitis. Some of them might be a little bit more surprised to see, so mycoplasma, flavivirus, E. coli. But there are a few things when you delve into this table, which is a systematic review of these causes, that were quite interesting. But first, we need to consider the cynical view here. So catatonia is not uncommon in patients admitted to hospital, even in a general hospital. And a cynical view of all these infective causes of catatonia is that catatonia is brought on by stress of hospitalization, or potentially many people are using benzodiazepines that they've bought online or getting on the street. And when they're brought into hospital, they don't admit to this, and they have sudden benzodiazepine withdrawal, which can trigger catatonia. Now, I'm not sure that these cynical views hold up, actually, because actually, if you look at the breakdown here, it's not a typical breakdown of hospitalized infections. We've got a big predominance towards CNS infections here with these viral and bacterial causes of encephalitis. And we've also got HIV and syphilis, which are neurotropic pathogens as well. And actually, only 13% of these patients were recorded to have a prior psychiatric disorder. Out of the 47 specific viruses identified, 45 of them were known to be neurotropic. There's a bit more mixed with the bacteria. So it looks like CNS infections are particularly the issue in causing catatonia. What about COVID-19? Is it possible that COVID-19 is going to lead to an outbreak of an encephalitis lethargica-like illness? Well, there's been lots of speculation, as you can imagine, about this. And there has been a systematic review of the 7 or 8 cases of COVID-19 and catatonia. And I'm aware of 1 or 2 unreported cases as well out there. So but it has been a handful of cases of catatonia and COVID-19. And moreover, there have been cases of catatonia reported in the current pandemic in people who have not been infected with the SARS-CoV-2 virus, but have experienced stress as a result of the pandemic. I'm part of a team that's running a blog for the Journal of Neurology, Neuropsychiatry, Neurosurgery and Psychiatry, which is trying to examine all the neurological and psychiatric associations of COVID-19. And we published this review in JNNP a week and a half ago, looking at all these CNS manifestations, everything from myalgia, anosmia, all the way through to depression, anxiety. And we have not found a big signal for catatonia. The Oxford group with Maxime Taquet and Paul Harrison published a couple of months ago in the Lancet Psychiatry 6-month neurological and psychiatric outcomes in COVID-19 survivors. This is the largest study today of this follow-up period. using a huge number of patients from US records. And they looked at various associations, but they looked at Parkinsonism, which, if you're thinking of an encephalitis lethargica-like post-encephalitic Parkinsonism syndrome, you would expect to see a rise in. And the numbers were very small post-COVID-19, and it didn't reach statistical significance when compared to influenza. So if there is a link to COVID-19 and catatonia, it's either a very not a very strong one, or it's a delayed one. We're not seeing massive evidence for it at the moment. What about the autoimmune causes of catatonia? Well, when we reviewed these, we found that there are about 350 cases reported in the literature, and more have come out since this point. But the real headline to note is that out of these 350 cases, more than 250 were autoimmune encephalitis. And almost all of these were one specific form of autoimmune encephalitis, the NMDA receptor encephalitis. So this is the massive headline if you're thinking of an autoimmune cause of catatonia. It's worth pointing out that there were one or two other notable causes. This was lupus with 50 cases reported. So it might be worth having that in the back of your mind, particularly if the patient has an arthropathy, malar rash, renal or pulmonary involvement. The literature on thyroid disorders was a bit of a mess, unfortunately, in 13 cases, but as you'll see from this table, it wasn't really clear whether the catatonia was related to patients being hyperthyroid, hypothyroid, or even euthyroid with just thyroid antibodies present. As I highlighted in the previous slide, the NMDA receptor encephalitis, but I do wonder whether the association with catatonia is just so strong because it's actually been studied, and there have been large case series such as Dalmal's series of 100 cases where all patients were assessed with catatonia. As you'll be aware, many other forms of autoimmune encephalitis haven't been studied with the same phenomenological care. And there have been a couple of cases associated with other forms of encephalitis, and we reported a case of catatonia associated with GABA-A receptor antibodies. Importantly, though, I think we've got to approach some of these cases with a little bit of skepticism. So in ours, there was an awful lot going on with this patient, and GABA-A receptor antibodies are fairly common in the general population. What about inflammatory markers across the spectrum of people with catatonia? Well, there have been a few studies, all of them fairly small, and creatine kinase was raised in one study, but two smaller studies didn't find it was raised. D-dimer was studied in one study and was found to be raised. Now, creatine kinase isn't conventionally an inflammatory marker, but is often raised in inflammatory conditions. D-dimer does tend to be raised in inflammation. And iron is an interesting marker because it could be a marker of many things, but crucially, it's a negative acute phase marker. So in states of inflammation, iron tends to be sequestered. And the idea behind this, which was developed in the 80s and 90s, is that iron is essential for bacterial growth, and the body sequesters it in order to prevent that bacterial growth as part of the inflammatory response. 3 studies have shown low iron in catatonia, but 2 have not. In terms of more conventional inflammatory markers, one study has looked at high sensitivity CRP. So these are patients who might not have a CRP that suggests infection, but still the values seem to be higher than non-catatonic patients. One study looked at the white cell count, didn't find any overall difference in the white cell count, but in one of the subgroups, they looked at the monocytes and found that these were a little bit lower among patients with catatonia who responded to lorazepam. We've had a look in our own data within South London and the Maudsley, and obviously this is retrospective data, and we're relying on the blood tests that clinicians have ordered themselves. So we're limited by that. We had a look at iron, and we found that it was a little bit lower in the catatonic patients than in psychiatric inpatient controls. But of course, there's a lot of missing data here. There are a lot of patients with catatonia who didn't have iron taken, and the same in the controls. And you can think about the biases which might cause patients to request serum iron on a patient if they're already anemic, although maybe that's not so different between catatonic and inpatient controls. So iron was lower. The CRP, we didn't find any significant difference between the two groups. Likewise with the ESR. The creatine kinase was much higher in the catatonic patients, and it didn't actually, we hypothesized this would be either due to excitement or rigidity or just inactivity and damage to the muscles from pressure, but we didn't actually find any associations with any of those. But raised creatine kinase, as you'll be aware, is very non-specific. In terms of autoantibodies, we looked for the NMDA receptor antibodies, and we found that out of 54 catatonic patients who had the NMDA antibodies examined in the serum, 3 were positive out of 54. And among 481 inpatient controls, 5 were positive. Now, this was technically statistically significant, but I would forgive you for a great deal of skepticism about these results, given that it's based on only 3 positive cases in the catatonic group. So what can we conclude from all this? So hypothesis 1, our idea that systemic inflammation drives the neurovegetative features of catatonia. There may be something in it, but it certainly doesn't explain features like echopraxia. That's much harder to link together with a kind of a post-viral or flu-like illness. And moreover, I think that the infections and the autoimmune conditions that we see, there's a massive predominance towards CNS predominant conditions. So we did not find lots of cases of Crohn's disease or pulmonary fibrosis associated with catatonia. It seems to be that it's something much more specific to the central nervous system. So I think this hypothesis struggles to explain catatonia. In terms of the second hypothesis, the idea that there are specific neuronal autoantibodies that can cause catatonia, well, it's definitely the case that NMDA receptor encephalitis accounts for some cases of catatonia, and certainly in NMDA receptor encephalitis, we see that 60 to 80% of patients have catatonia at some point in their illness. It seems to situate glutamate as fairly central to catatonia pathophysiology, particularly when you add in the fact that ketamine, a negative allosteric modulator at the NMDA receptor, can also cause catatonia, as can PCP. Although it is possible that other antibodies may have a role, and I think we need to phenotype some of these other autoimmune encephalitides more carefully to look for catatonia. How viruses may cause catatonia, I think, is still very unclear. Is it through CNS inflammation? Is it through a more specific action on certain receptors? I think that will remain to be untangled. So, key points to take away. Firstly, catatonia is associated with numerous infections and autoimmune disorders, but at the top of your differential, you want to have CNS-specific causes. And I think the main ones you want to be thinking about when you approach a patient with catatonia, where you think there might be an inflammatory cause, is NMDA receptor encephalitis, lupus, HIV, and herpes simplex virus encephalitis. I'd very much like to thank my supervisors, Tony David, Glyn Lewis, and Mike Sandy, among many others. I'm very happy for people to get in touch. And we now have a website hosted by the UCL Institute for Mental Health, which provides information for both clinicians and patients on catatonia. Thank you very much.
Thank you very much, Jonathan. Very interesting presentation. We already have several questions here. The first one is from Professor Belinda Lennox. Thanks, Jonathan. Great talk. How much of a problem is that we are not very good at picking up catatonia? How common do you think it actually is in general medical wards in those with infections?
Yeah, it's a great point. I think catatonia is underdiagnosed. There was a Van der Heyden study in 2018, which compared catatonia diagnoses between just what clinicians have recorded and between researchers going around with clipboards looking for catatonic features. And the first found a prevalence of 2% on inpatient wards, and the second found a prevalence of 18%. I'm a little bit skeptical about both those extremes, actually. I think it's something in between. Within SLAM, we have between 100 and 150 cases of catatonia each year. And we found actually that, if anything, over the last 10 years, numbers of cases seem to have gone up rather than gone down. So it's certainly not dying out. But of course, as you allude to, we're missing a lot of patients there who are in a general hospital. I've seen several cases with catatonia in general hospitals, predominantly on neurological wards, but I think that's because this is a bit more on neurologists' agendas than some other specialists. Certainly, there's a growing literature on catatonia in the intensive care unit, and particularly on the comorbidity between catatonia and delirium.
Thank you very much. Another question is from I think it's Dr. Umesh. Apologies if I didn't correctly pronounce your name. Very interesting, thank you very much. Any studies on paraneoplastic syndrome related catatonia?
Interesting. I suppose the one that would come to mind is anti-GAD antibodies, so glutamic acid decarboxylase, and obviously there's some controversy as to how pathogenic these antibodies are, and obviously GAD antibodies can be paraneoplastic. It does present sometimes with a phenotype that's very similar to catatonia, with the intermittent muscular rigidity and also the severe anxiety. But I'm aware you've got an expert in the next seminar talking about that, so I will leave it to Dr. Crisp.
Thank you very much. Just to ask our audience whether we have any other questions for today. Okay, we have another one from Belinda. Oh no, that's the old one. Thank you very much. I don't think we have more questions. Just to let everyone else to have some time to type a question. No, so maybe we should close here. Let me just see another chat. No questions, okay. So we have reached the end of today's webinar. Thank you very much, Jonathan, for this very interesting presentation. Thank you also everyone for attending. We hope you found the presentation interesting and informative. We invite you to join our next webinar at 10:30 a.m. on 22nd of June, next Tuesday, next week. And the presenter is going to be Dr. Sarah Crisp from University of Cambridge. Thank you, everyone, and enjoy the rest of your day.